Okay, today we are going to start by having a discussion on some selected male reproductive disorders. So the first one we're going to talk about is benign prostatic hyperplasia. So the name actually has everything you need to know about it. It's benign. It affects the prostate and it involves an increase in size and in some cases numbers of cells. Benign prostatic hyperplasia. And as a quick review, we will take a look. Okay. At our male reproductive system. Let's make that a little bigger so we can see it. And the structures we're going to be looking at and some of the pathologies today are the prostate gland located inferior to the bladder. So here's our bladder, and this beigey structure I'm outlining in blue is the prostate gland. So we can see that the ejaculatory ducts, two of them, are going to enter into the prostate gland and join with the urethra that empties the bladder to form a common duct shared by the male reproductive system as well as the urinary system. And the rest of the duct will enter and travel through the penis to exit. So this duct system that it was initially began in the testes. So here's our testes. And this represents the epididymis, and the duct that leaves the epididymis is the ductus deferens or vas deferens. It leaves the scrotum, travels over the symphysis pubis. Remember, there's going to be two of these, right and left, and into the pelvic cavity, sort of lateral along the upper parts of the bladder, behind the bladder, and traveling through the seminiferous tubule, collecting up the volume of semen that's going to be produced by the seminal vesicles, and then again from the prostate, about 60%, about another 25 or 30% contribution from the prostate, and the last smaller percentage from the bulbourethral gland, all contributing to the semen that supports the viability and motility of the spermatozoa that were produced in the testes. So we can see that the testes are outside the body, and we're going to be talking about a condition where the testes fail to descend, which means they would remain up in the pelvic cavity, up in this area. So the prostate, the undescended testes are the main topics that we're going to be talking about with respect to some male disorders, and later on we'll be speaking about infertility, but these are the structures that we want to be aware of. All right, now, when we talk about benign prostatic hyperplasia, it's also just simply describing an enlarged prostate. It has basically an unclear etiology. We know what happens in many of the cases, but not exactly why it happens, other than blaming everything on getting a little bit older. So keep in mind, just as a reminder, males have a prostate gland, females don't. So this is going to be a condition that would not be expected to affect females, given that the target tissue doesn't exist in females. So basically, risk factors include a first degree relative, type 2 diabetes is another one that's a known risk factor. Obesity increases the risk, goes hand in hand with type 2 diabetes in a lot of cases. Sedentary lifestyles, the conditions that are related to pre-diagnosed type 2 diabetes, like glucose intolerance or insulin resistance, a poor lipid profile, those sorts of factors. We could summarize all of that up with what is sometimes described as metabolic syndrome. Certain medications will also increase the likelihood of BPH. Medications like anticholinergics and pseudoephedrine, which isn't as available as it once was, calcium channel blockers. Those are all factors that may increase risk. So we'll just summarize that as some medications. And the idea here is that when we look at the pathophysiology or pathogenesis, essentially the concern is that the prostate grows or enlarges and encroaches or presses on the urethra. So when we get a press on the urethra, we're going to get changes in urinary output. Whoops. We get an increase in frequency. Sometimes a little bit of difficulty or pain in getting started, maybe even some urgency. It tends to increase urinary nighttime disturbances, requires getting up more often. And that's basically what the diagnosis is going to be made from, is these kinds of symptoms after ruling out some obvious other options that have a more negative impact, such as prostate cancer. So once those are ruled out, but these symptoms are left, then we're actually talking about this reduced flow through the urethra due to this increase in external pressure. The main mechanism seems to be related to aging. So what seems to happen with aging is that there are some changes to some growth factors associated with the prostate gland and some changes to endocrine factors with aging that have a direct effect on the prostate in a significant number of men over the age of about 50 years or so. So basically, there's a loss of homeostasis between cell growth and apoptosis. And you remember that apoptosis is essentially the body's way of regulating tissue and organ mass in many cases based on environmental factors, but it's a natural removal or destruction of cells in the interest of maintaining homeostasis of function. So basically, this imbalance is obviously going to favor proliferation. That's where we get the hyperplasia from. So there's going to be an increase in the number of cells associated with the prostate gland, and many of the different various cells seem to be affected. So basically what happens is with age, with increasing age, men develop a increased ratio between estrogen and androgens. So what we know happens in again, a significant percentage of men is that with aging, enzymes that are responsible for converting androgens to estrogen increase in their numbers and in their activity levels, so that more androgens will be converted to estrogen. And when estrogen targets the prostate gland, it has a proliferative effect on the prostate gland. So when we increase the ratio of estrogen to androgens, because of increased enzyme activity, estrogen targets estrogen receptors on the prostate gland. So the prostate gland is described as having hormone responsiveness specifically to estrogen in this case, and those activated receptors promote proliferation of most of these prostate cells. So some of the evidence that supports that this is the primary pathway, the primary pathophysiology that's going on, is that men who have had their testicles removed at a young age, for example, because of testicular cancer, or possibly for an undescended testes that has resulted in testicular damage that's irreversible, they don't get BPH. And basically that means that the elevated levels of testosterone that are found in healthy men can't get converted to estrogen. So part of the group of androgens is testosterone. So with low levels of testosterone or absent levels of testosterone, there isn't that extra conversion that's going on with aging. So if BPH is going to begin, it's typically going to happen after the age of 40, and peaks in their 70s. About half of males over the age of 50 will be affected. So as aging progresses, that percentage increases. So again, these are not numbers I'm going to ask you about, but I expect you just to recognize the fact that with aging, the incidence or prevalence, I should say, is going to increase. And it's basically due to this imbalance between proliferative effects and apoptotic effects. So the other thing to keep in mind is that one of the, we talked about this when we talked about prostate cancer. We know that one of the markers in the blood is the prostate-specific antigen. And although those levels might rise in BPH, they do not increase the risk for prostate cancer. So BPH does not increase So we mentioned some of the symptoms. What's interesting about this BPH, if you remember the picture I showed you, our prostate gland sits under the bladder and has an entry point and essentially an exit point. We'll kind of draw it up like this, so that the urethra leaves the bladder and then leaves the prostate gland, but picks up from the ejaculatory ducts that entered the prostate gland. So like we've talked about with organs or tissues that had an entry point and an exit point, we can talk about symptoms and the presentation with respect to pre-prostatic factors, intra-prostatic factors, and post-hepatic, not hepatic, prostatic factors. So basically, we can divide the presentation as storage, voiding, and after. In other words, pre, intra, and post. So when we look at storage symptoms, we're really talking about storage symptoms that are going to affect the bladder's ability to store because of the hyperplasia. The volume that the bladder is capable of containing is going to be reduced. So we're probably going to see polyuria, nocturia that we've talked about, we've mentioned, but this is sort of focusing in a little bit. Possibly some urgency because the bladder fills sooner. There can be some, if it's progressive, involuntary urination, and that might happen a little more frequently at nighttime. When we look at voiding factors, we're going to see some things like hesitancy, intermittency, so basically what we're saying there is it's discontinuous. So sometimes the hesitancy is having trouble getting started, and then intermittency is in the midstream, it may cease and then have to start again. Weak urinary stream, and possibly some uncontrollable leaking. These symptoms are often accompanied by some bladder pain or pain while urinating, and that we know by now is called dysuria. when we look at factors that involve post, what we're looking at there is obstruction, essentially. So we're looking at our post is going to be obstructive factors. So when we look at obstructive, because the growth of the tissue gets to the point where it may actually cause closure or significant reduction in the lumen of the urethra, and that may actually promote some abdominal pain. Because there's going to be some retrograde flow. So there's an inability of the bladder to empty, even though it may be signaling that empty. So those contractions are going to get more significant. You're going to have a full bladder and the feeling of a full bladder, sometimes even when it isn't full. That sort of thing is the way that we're going to see some frequency. What else do we need to consider here with respect to some retention? That's the same thing. The dysuria that we've talked about already, and nocturia. So it's just a progression of what we've seen in the previous descriptors. So what are we going to do for these? Just consider that BPH is usually progressive in nature, so these symptoms are going to progress if there isn't an intervention of some sort, especially if untreated. So incomplete voiding is going to promote residual volume or urinary stasis, and that's going to increase the risk of urinary tract infections. So incomplete voiding is going to increase our risk for urinary tract infection. Our diagnosis is going to be initially based all on clinical history and examination, and ultimately a digital rectal exam. So basically what we're looking for in the digital rectal examination is palpating the prostate gland rectally and expecting to find a symmetric and smooth glandular tissue. That supports our diagnosis of BPH. If the prostate gland feels asymmetric, firm, or nodular, this raises the possibility or increases our index of suspicion for prostate cancer. So BPH, the palpation reveals smooth and symmetrical tissue. Prostate cancer would be nodular asymmetrical, and firm. So that's the differential there as far as that's concerned. So what do we do for these patients with respect to treatment? A nice conservative term, watchful waiting. If progression seems to be slow and other than the inconvenience of the frequency and so on, then there isn't much purpose in intervening in the early goings. Few lifestyle changes, like the same things you might suggest to a child who's got a bedwetting issue as they learn to voluntarily withhold the volumes in their bladder. You may suggest that, no drinking fluids after supper, that sort of thing. Avoid drinks that we know are diuretic in nature, like caffeine drinks and alcohol-based drinks. Limit those, especially in the later half of the day. Be aware of medications that might be diuretic in nature, especially for treatments, for example, for hypertension. Maybe the time of day that those medications are going to be taken need to be adjusted. So we'll categorize all of that as sort of lifestyle changes, maybe / awareness. And then if those are not enough to improve the quality of life, then more invasive measures can be taken. There are some medications that can be suggested, and even surgery to remove at least part of the prostate gland to relieve those symptoms. So basically, when we look at medications, they're typically designed to decrease the activity of enzymes that convert androgens to estrogen. So one of the enzymes that is a known converter of androgens to estrogen is called 5-alpha reductase. That's the enzyme. So the medication is an inhibitor. And there's some other examples. The other big enzyme that's involved here is an enzyme called aromatase. And there are medications that are known to be aromatase inhibitors as well. So those are the two big sort of family of enzymes that will convert androgens to estrogens. So these are the types of medications that can be applied to try to reduce that proliferative effect that estrogens have on the estrogen receptors of a prostate gland. Now, and then I'm just going to put over here, because I don't want to start a whole nother. Surgical options include options that would be designed to remove part of the prostate gland if they're not improving with these other less invasive mechanisms. There is some indication too that there are certain herbs and natural products out there that have some benefit for those with BPH, benign prostatic hyperplasia. And of course, research on those needs to be done a little bit more diligently to give some better evidence base. But certainly from an anecdotal point of view, there's some benefit from some natural products out there. Pumpkin seeds are an example, and stinging nettle root are another example. But again, not generally widely recognized or accepted by traditional medicine. Okay, now what about prostatitis? Prostatitis is not the same thing as benign prostatic hyperplasia. In prostatitis, it's an inflammatory condition that's going to present very similarly. So it has to be a differential. So the name tells you it's got an inflammatory component to it, inflammation of the prostate. So it can affect any male at any age. So it's different already because of the group that is susceptible, right? We said that with BPH, the susceptible group is men as they approach middle and late and elderly age groups, with a peak in the mid to late 70s and a significant number of men over the age of 80 having some degree of hyperplasia. Prostatitis can happen in any male at any age, and it's the most common urinary tract condition to affect males. So I should say it's relatively so there's a few different variations on prostatitis. It can be described as acute or chronic, bacterial prostatitis. So this is prostatitis that develops as a result of a bacterial infection, obviously. Chronic prostatitis or chronic pelvic pain syndrome, which is prostatitis that has no exact cause. So we can have another variation of chronic prostatitis. So chronic. So we have this type of presentation, and we can talk about an asymptomatic and that's just like it sounds. This is a prostatitis that does not cause symptoms, but is going to nonetheless affect functions of the prostate gland. So when we look at the symptoms of prostatitis, they're going to overlap significantly with BPH. So presentation or the signs and symptoms, we're going to have some pelvic pain. And that can range from mild to severe. You can appreciate that often the acute onset is going to be a little more severe, and chronic is going to be a little more insidious and gradual in its presentation. It may actually even give flank or low back pain. So it needs to be differentiated from other sources of problems that might affect those areas. Dysuria, frequency, so you can see that when you look at these sorts of symptoms, they're very, very closely related, and it becomes a very important differential diagnosis to BPH. Sometimes there may be some blood in the urine, hematuria, so we have to differentiate that from other renal dysfunctions. And it may have a impact on the reproductive functions of a male as well. It may, for example, ejaculation may be very painful. And again, because of the infection, you can expect in cases other than our option C there, the asymptomatic prostatitis, you can expect that there would be some fever and chills and body aches associated with the infectious process as far as that goes. So what are we going to do to treat these guys compared to what we would do with someone with benign prostatic? For the acute forms, so for our type A group that we talked about, prostatitis, we got a couple options here. We're going to treat the specific bacteria. So antibiotics that target the specific bacteria that are causing the infection. So I'll write it down just so we're complete. Antibiotics or antibacterials. For chronic prostatitis, we may need a longer course of antibiotics, often lasting from weeks to months. The choice of antibiotics is going to be based on the results of urine and prostate fluid cultures. So that's the idea behind being specific. We'll just say longer treatment when chronic. For our middle group there, the chronic prostatitis, where we can't identify the organism that's causing the inflammation. This is also sometimes called chronic pelvic pain syndrome in males. So treatment is going to be symptomatic pain relievers, I think we got to do that. Better spell that the right way. Sometimes alpha blockers might be used to relax the muscles around the prostate. They're used also in benign hyperplasia situations as well. So the alpha blockers are designed to relax the smooth muscle around the prostate and the bladder. Pelvic floor exercises can help sometimes. Lifestyle modifications, decrease stress. You might remember from the discussion in the male reproductive system, we talked about the role that the sympathetic division plays. So during stressful situations, the sympathetic division of the autonomic nervous system dominates. One of the effects of the sympathetic nervous system on the bladder is it's going to promote the sphincter to contract so that the bladder doesn't empty under stressful circumstances, typically. So that's where the alpha blockers can play a role in that respect. So doctors can also suggest some anti-inflammatory medications and so on. So those are pain relievers, So for the asymptomatic prostatitis, obviously there's no specific treatment that's needed. It's not causing symptoms, so there's nothing to treat from that perspective. We talked about the treatment approaches for benign prostatic hyperplasia already. So basically there is a section in the course outline that says compare prostatitis to benign prostatic hyperplasia. So we've just done that. We've just described very quickly what the presentation of prostatitis looks like compared to benign prostatic hyperplasia. So essentially, the difference between the two is the inflammatory component and the approach to treatment based on that inflammatory component. Okay, cryptorchidism. Cryptorchidism. This is the condition in males that's also described as being undescended testes. So it's the failure of one or both of the testes to descend into the scrotum. Failure of one or both testes to descend to the scrotum. So it's also described as the most common birth defect in the male genital tract, and a very small percentage of full-term boys and a higher percentage of premature boys will be born with at least one undescended testes. So I'll put numbers down, but know that you're not going to be asked questions about these numbers. About 3%, so the numbers are really for reference purposes only, of full-term boys and maybe as high as 30% of preemies So that's the incidence that we're talking about. Now, one of the things that puts these numbers in a little bit of a perspective that actually you can consider these numbers in reality to be lower, because oftentimes what's going to happen is as the boys mature and grow and develop in that first 6 months, 3 to 6 months typically, and maybe as long as a year, these undescended testes often descend on their own. So that would actually put the incidence much lower than the 3% in full-term boys and 30% in premature boys. So most undescended testes descend in the first year. And the majority of those are going to happen in the first 3 months or so. So it's just a little bit of a delayed reproductive maturity in that respect. Now, occasionally, cryptorchidism can develop after infancy, sometimes as late as in young adulthood, but that's really, really rare. And that would be a situation where the testes were descended and they actually retract. There is a condition where one of the differentials that needs to be considered in cryptorchidism is a condition where the testes are described as being retractile. In other words, they're quite mobile. And that's sort of a normal function of the testes. There's that muscle called the cremasteric or cremaster muscle. And the cremasteric reflex is designed to retract the testes back towards the pelvis. In some males, it may actually re-enter the pelvis, but also, when the cremaster muscle relaxes, return back to the testicles. So that would be described as a retractile testes. And that they're a little more common than the truly undescended testes, and they don't need to be treated. generally speaking. So the concern we have is that undescended testes increase the risk of infertility. And if we recall what part of the reason for that is that the location of the testes in the scrotum was intended to decrease the environmental temperature for spermatogenesis. In other words, the scrotum is away from the core of the body, relatively speaking, and provides an environment that's generally somewhere between 2 and 3 degrees Celsius cooler than body core temperature. And that tends to be an environment that's more favorable to spermatogenesis. So if the testes are in the pelvic cavity, the environment is much warmer and it's going to interfere with spermatogenesis and therefore decrease the viability and motility of the spermatozoa that are produced there. In other words, increase the risk of infertility. So the after 1 year, if give or take, if the testes has not descended, a procedure called orchiopexy is recommended. So that's surgical descending of the testes. So the surgeon will go in and will direct the testes into the scrotum. So basically, that's a fairly successful surgical procedure if it's done in that sort of first year to 18 months, if it hasn't descended naturally. And that's in order to prevent the possibility of infertility with respect to that particular testes. From your understanding of normal male reproductive functioning, the testes are responsible for producing millions upon millions of spermatozoa on a daily basis in order to make hundreds of millions available in the interest of fertilization. So without one of the testes being functional, those numbers are going to be significantly reduced and significantly contribute to the possibility of infertility. So the patho basically, the pathophysiology is related to environmental temperatures the effects on spermatogenesis, like we talked about. So it isn't going to be just about that, but that's going to be a big factor. The other considerations is that if the testes did not descend naturally, there may be some other factors that are coming into play. And they may be related to endocrine factors associated with low levels of testosterone or secretions from the anterior pituitary gland that interfere with the normal descending of that testes. Now, the other consideration is that an undescended testes is a cancer risk. So one of the things that we know is that an undescended testes increases the risk for testicular cancer. And it's a pretty significant number. About 1 in 500 men born with an undescended testes is going to have an increased risk for developing testicular cancer, anywhere, based on the research that's out there, anywhere 4 to 40 times an increased risk. So again, numbers that we don't need to memorize, but understand that if a boy is born with undescended testes, his risk for testicular cancer significantly increases. And the likelihood of testicular cancer is often going to occur a little bit earlier in their lifetime. So so not only is there an increased risk for cancer, but it's going to happen at an earlier age as well. So one big advantage to the surgical intervention is that even though the risk is higher, the cancerous mass that's growing in the scrotum is more easily detected than if it was growing in the pelvic cavity. So as we've talked about when we talked about cancerous tumors, oftentimes it's the mass of cells that create the symptoms, the stretch or the pressure on adjacent tissues, or the space that the growth is occurring in. So if that growth is going to occur in the scrotum, it's going to be detected, it's going to be more noticeable, and it's going to allow an earlier intervention. So that's another advantage to the surgical direction of an undescended testes in a boy. The risk of malignancy is much higher, not just the development of a cancer, but malignancy as well is higher if in the presence of an undescended testes. So who's at risk for an undescended testes? Obviously, premature. If there's a family history. Cerebral palsy increases the risk. Okay, obviously, if there's already some structural or functional changes, that's going to increase the risk of some additional ones. Maternal diabetes, either during gestation or before, and obviously after. Alcohol, smoking during pregnancy increases this risk. So again, risk factors that we can pretty much list for any pathology that we've been talking about include alcohol and smoking, and no different here as far as that goes. So exposure to some pesticides. We'll just call those environmental toxins. Increase the risk as well. So how are we going to make this diagnosis? Most common diagnostic dilemma is that in otherwise normal boys, you have to determine whether it's a retractile testes or an actual undescended testes. So retractile testes, as we talked about, they're more common, and younger boys have much more range of motion in that retractability than adult men would have. So the testes typically in an adult man, even as it retracts, typically will not retract all the way into the pelvic cavity, but in younger boys that can happen. So the diagnosis could be incorrect if in fact it's at a time when the testes had just retracted rather than be undescended. So have to determine between undescended and a retractile. So that's important, and that may require more than one examination, because on a single examination, it may have been retracted, and at a subsequent one may not be. So that will preclude any need for treatment if it's determined to be retractile. So remember, that's based on that cremaster muscle function that we've already talked about. There are some genetic pathologies that result in hypogonadism. Individuals that have some genetic variations, chromosome patterns, XXY, YYX, there's different possibilities that would increase the likelihood of an undescended testes or a presentation of a scrotum or partial scrotum with no testes associated with them. So those are all factors that have to be determined before the diagnosis is going to be made. So again, with treatment, we'll just put chromosomal abnormalities there. With treatment, we start with that term, watchful waiting, because there's a good assumption that the testes will descend naturally or so-called spontaneously in the first year or so of the infant boy's life. And if it doesn't, then the orchiopexy is that gold standard for an undescended testes, especially as the infant boy approaches 12 months to 18 months of age, and it hasn't yet descended. So after 12 to 18 months, orchiopexy is the standard treatment. And that's to prevent degeneration of the testes within that pelvic cavity where it's too warm for proper spermatogenesis to occur. If it is determined that the undescended testes is degenerated beyond function, so no longer capable of spermatogenesis, then they can be removed. And then again, in that situation, removal of the testes in that circumstance decreases the risk for testicular cancer in that individual's future.